Good evening, everyone, and welcome to our second research club in 2022, hosted by the Brain Health Center of the Rockies. My name is Kathy Kiefer, and I'm the president of this nonprofit organization. We have two speakers for tonight's session, Dr. Augusto Miravalle, who will be discussing the latest updates in pain care, and Dr. Tamara Miller, who will be giving us a review in migraines. The intent of our research club is to bring the latest developments of recent academic journal articles and have them explained in a way that anyone can understand by a panel of experts. We hope that through this activity, participants will receive useful concepts that they can apply to their daily lives to achieve maximal brain health. Research Club is a free program to our participants. It will be held 4 times throughout the year. Our next 2 research clubs will be September 12th with the topic of air pollution, global warming, and brain health. Is there a connection? And November 7th with the topic of food for thought, food, nutrients, and the brain. Today's event is being recorded and will be made available via our website, www.brainhealthcr.org, within the next few days. All of our research clubs are held on Monday evenings starting at 5 p.m. Mountain Time and are only last 1 hour long. I hope that you folks will use the Q&A box at the bottom of your screen to ask any questions you might have during the presentations. We will allow time for Dr. Miravalle and Dr. Miller to answer as many questions as possible during the time frame allotted. Our moderator and co-chair of our research clubs is Dr. Brett Fling. Before I turn this over to Dr. Fling, I would like to mention our sponsors for tonight's event, which include Biogen, Bristol Myers Squibb, Genentech, Novartis, EMD Serono, Theranica, Lundbeck, Biohaven, AbbVie, and Amgen. You can find information regarding these companies as well as their products by visiting their virtual exhibit hall on our website. At this time, I'd like to turn it over to Dr. Fling. Thank you.
Thanks very much, Kathy. That's an awful lot of sponsors. That seems like a good sign. I guess this is a topic of interest to folks. Just as Kathy said, we really want to encourage anyone who is watching live along with us to use that Q&A box. You can see it at the bottom of your Zoom screen if you move your mouse around a little bit. And feel free at any time a question pops into your head to go ahead and type it in there. I'm going to jump in and interrupt Drs. Miller and Miravalle every now and then, and we'll relay your questions along with, I've got a few of my own I've been thinking of. So by all means, just whenever you think of a question, you don't need to wait until the end. Pop it into that Q&A box, and then I'll move forward and interrupt. Okay, well, let's go ahead and start moving forward, if you don't mind, Dr. Miravalle. And so again, as Kathy pointed out, we're interested in discussing pain today. And I think to get us started, this is a pretty ambiguous, amorphous, whatever the right term is. Pain is hard to describe, and it sort of means something a bit different to everybody. So maybe to get us started, Dr. Miravalle, you can talk to us a little bit about, as a clinician, what do you think of when someone reports to you with pain? How do you identify it? How do you determine and delineate between different folks?
Absolutely. Thank you, Brett. And it's a pleasure being here and with Dr. Tamara Miller, who is truly an expert in the subject matter and an amazing colleague and good friend too, which is always good to know. So in terms of pain, as you mentioned, Brett, it is truly challenging, not only because of the multimodal qualities of the symptom itself, which we will talk about it, but also the description used from patients and the intensity perceived truly depends from person to person. And this chart tries to exemplify the different domains involved in pain. First of all, pain is a sensory phenomenon. So what that means is pain is carried through the nerves that are specialized in different types of sensations, whether it's touch and temperature, pain is one of those. Also, we need to remember that pain is part of our survival mechanism, right? So the reason why we perceive pain is to alert us in situations that are potentially dangerous, right? So if we put our hand in the fire, our brain needs to know that that's a noxious stimulation and we need to preserve ourselves. So in a sense, we are designed to have pain as part of our survival mechanism. The other principle that we need to remember is this concept that pain feeds pain and pain breeds pain. So the more pain we have, the higher the intensity and the frequency of that stimulation is, the more sensitive the brain becomes to perceive pain. And that's one of the underpinning mechanisms to explain chronic pain syndromes. And we'll go into a little bit more detail. And then the last thing that we need to remember is in order for us to perceive pain, we need to have cortical activity. There is a lot of controversy in the field of terminal medicine in terms of, do people in coma perceive pain? And we know that you need to have some minimal conscious state in order to be able to perceive pain. So the perception of pain depends on cortical activity. However, the stimulation of pain can get all the way to the thalamus and the subcortical structures, and patients can perceive pain. However, it depends on that conscious stimulation and perception in order to understand what pain is. And that depends on individual to individual. So we kind of categorize pain in different ways, but one way that is very practical for today's talk is this concept of acute versus chronic. And that's mostly time dependent. So acute pain is that lasts less than 6 months and usually subsides once the healing process is accomplished. And most importantly, once the stimulation that created that pain is gone. So if if you're walking and you bump your knee to the furniture, that's an acute pain and goes away. Chronic pain is perhaps more complex, and that's the one that lasts more than 6 months, that is going to involve these complex processes involving sensory inputs to the brain and pathways coming from the brain to the periphery. And it has to have some degree of altered anatomy and structural processes involving the pathways in the brain and also the chemicals that allows those brain connections and these nerves to communicate with each other. And so chronic pain is what we're going to talk today. Chronic pain could be still subdivided into different types of chronic pain. The so-called nociceptive pain, that's the typical musculoskeletal type pain, the one that you see in people with rheumatoid arthritis, with osteoarthritis, that is mostly a pain that comes from the receptors that are present in the muscles, in the joints. There is also a type of pain that we call neuropathic pain, the one that comes directly from the nerves, the end terminal of the nerves, from the connections between the nerves and the brain cells, the neurons, and all these receptors. And that's the type of pain that is involved in stroke, for example, in multiple sclerosis, in migraines. Dr. Miller will talk to us about migraines. So that's the type of central neuropathic pain. But it's also present in other type of pain syndromes like neuropathies, for example, in post-viral syndromes like zoster and post-herpetic neuralgias. And then we have another type of category of pain that is that visceral pain. If you have a heart attack, those cells are dying, that's going to send signals through the visceral nerves to the brain saying, hey, something is happening here, you need to do something. So that's more of a visceral type of pain that comes from the GI organs, from the heart, from all these vital organs. And then you have this mixed category of different types of pain that can coexist. By the way, this is a great article that I put the reference there in case someone wants to read a little bit more about pain, that was published in Nature Reviews in 2017 and gives a wonderful review of the different types of pain. So as I said before, today we'll talk about chronic pain, and within chronic pain, the neuropathic category of pain. So chronic pain is very prevalent. It involves over 30% of Americans, and those who are over the age of 65 could be as common as 40% of the population. In different neurological disorders, it's very common, like in the case of transverse myelitis, in the case of neuromyelitis optica, and of course, multiple sclerosis that could be seen up to 86% of patients. As I mentioned before, neuropathic pain is a type of chronic pain that is caused by problems in the wires, in the nerves. And we can divide those nerves into different types, but there are fibers that we call the A beta, A delta, and C fibers. All three of those carry nociceptive signals, meaning painful signals to the brain. This type of pain is not as common as the other types of pain, but could affect up to 10% of the general population. And it has some relationships with aging, of course, with certain toxins that are known to be neurotoxin, like alcohol, smoking, diabetes, could be seen in the case of medication side effects like certain chemotherapies, vitamin deficiencies. We always talk about the vitamin B complex being one that is being associated with neuropathic pain, but also infections. And we'll talk a little bit about the COVID-19 and how we are learning that that is a very common cause of resurgence or de novo initiation of pain syndromes in general population. Going back to the article that I mentioned before, that gives us a little bit more in-depth distinction of the different types. And certainly we will not go into detail today, but this is just to convey one message to our patients, which is it's very important for your provider to understand your pain. And one way that you can help is if you draw in a cartoon, what are the areas that you feel pain? Because depending on the location of that pain, it helps us understand the type of pain. So a typical will be what we call the stocking glove distribution that is right here on the neuropathy, a type of pain that affects symmetrical distal hands and feet. But also we can see pain in the face, pain in the different dermatomes in the body. So the message here is, in order to help us help you, please draw in a cartoon where are the areas of pain. That is one of the critical aspects of trying to diagnose the right type of pain. And just to kind of wrap up this first section, which is what is pain and how do we distinguish the different types of pain, I thought to just present how complex the pathways involved in pain are, with the sole message to make sure that patients understand that it often takes more than just one pill to fix pain, right? So it's more than one modality to allow your providers to help you with pain. It's not as easy as it sounds. So chronic pain syndromes usually involve what we call abnormal peripheral nerve function. So these wires have some sort of dysfunction. Also the processing between the wires, right? The chemicals that are involved in the connections in the brain. Dr. Miller will talk about what is called the CGRP pathways, and that's critical in pain, understanding pain syndromes. But also at the level of the neurons, those cells that actually help us understand these signals, there might be some dysfunction at that level. And this is again to show you how complex the pain pathways are, that goes all the way from the receptors in the nerves to the spinal cord, from the spinal cord to the brainstem to the cortex, and then come back on different pathways. Sometimes these pain syndromes communicate with other responses, like visceral reactions. Often patients with chronic pain syndromes have nausea or vomiting or anxiety or fear. All these behavioral type of emotional responses is still part of the pathways of pain. And I want to bring home another really interesting new area of research in pain, which is this area called the dorsal root ganglion. So that's a group of neurons or brain cells that are outside the brain, right? We always think of neurons in the brain, but we do have a bunch of neurons in different locations. The ganglia are locations in which you have these satellite groups of neurons. And that's one of the first steps in the pain pathways. And from there, these signals are going to be kind of like integrated, modulated, and sometimes amplified to then transmit all the way to the brain. Well, guess who discovered these neurons now? Our good friend or bad friend, COVID-19. So this virus, in its attempt to continue to colonize us as new hosts, discovered the dorsal root ganglion. And it's been described, this overexpression of the receptors that this virus is going to recognize, called the ACE2. So for some reason, this virus is trying to get into our brain through different mechanisms. The nasal route, which we learned very early on, causing decreased sense of smell or hyposmia, also causing what is called chemesthesis, which is decreased sensation to taste to, for example, chemical compounds. People with COVID-19 have told us that they have decreased sense of taste to, for example, capsaicin or hot peppers or certain spices. Well, that's because of this invasion of the virus into these nociceptive fibers. But also the virus is getting into the ganglia, the dorsal root ganglia. And that's one of the mechanisms that is thought to be behind this incredible resurgence of pain syndromes that is being described in post-COVID-19 infections, anywhere from migraines, headaches, back pains, neuropathic pains that could happen in people with prior history of pains or people that never had pain, that all of a sudden, because of this invasion into this ganglia, are developing new pain symptoms. So with that, I thought to kind of wrap up the first question, and hopefully I was clear in this incredibly long journey of explaining what pain is. That is not simple, it's very complex and involves these neural pathways. Oh, I forgot that I decided to amplify the picture. So to show you how this COVID-19 virus likes to get through the nose. And there is this plate that we all have. It's a very thin lamina of bone that has small little perforations. And through those perforations, there are these nerve end terminals that allows us to smell, right? Well, the virus likes to get through the brain through that, which is one of the ways it gets to the brain. And directly through the olfactory bulb, and then from there go through these end terminal signals that could be linked to certain pain syndromes.
We didn't know you're so good at animations as well, Dr. Miraval. This is quite a slideshow to get us started. To those who may have joined us a minute or two late, just want to remind you to please, as we go along, feel free to type questions into our Q&A or our chat box, and I'm going to interrupt Drs. Miller and Miravale every now and then to hit them with a few, and we've had a few good ones in there so far. So Dr. Miravale, I thought maybe I'd start with you with a few questions. When you're receiving this pain as feedback, is there a chance that this alters the way then that you might want to contract or activate muscles? So can increased pain or pain perception maybe result in more spasticity, for example?
Absolutely. It's a feedback loop, right, that we often see with chronic pain symptoms. In an attempt to avoid getting pain or perceiving pain, often people don't move as much, right? And a consequence of that is, the joints involved in that movement may frozen and freeze, and that's a frozen shoulder symptom that we often see in older people. But also spasticity may happen, right? So there are these secondary consequences of pain that usually involves a movement or lack of movement, spasticity, and that concept of pain breeds pain, right? So from what starts as a neuropathic pain often evolves into more of a musculoskeletal type pain.
Yeah, so that's really interesting. One of the other things that popped up in our Q&A boxes from some of the folks watching right now is the idea of, maybe some of us have heard of the idea of a pain threshold, or someone has maybe a high pain tolerance. And so, you've talked to us about how complex pain can be, and you might ask a patient to draw on a map of a body where they're feeling pain, or where that pain is manifesting. What sort of dictates from person to person what they feel as a lot of pain versus another person who doesn't sense as much pain? And how can you rate this across different people?
Right, so we could rate in terms of intensity. There are different scales that we can use. And some of those are just visual type of scale, right? With the smiley faces. Tells us, how intense this pain is to you. And that's another important factor. In terms of the thresholds for pain are determined personally, but also culturally, right? So there are different aspects that determine that tolerance to pain. But interestingly, in this desensitization that happens over time, even regardless of your pain thresholds, if you have chronic pain, that constant stimulation may decrease that threshold of tolerance to the point that now you're becoming more sensitive to pain. And that's why it's important to try to mitigate pain as soon as possible to prevent that desensitization of the pain threshold.
Thank you very much. Well, I'm going to, in the interest of time, I'm going to keep us moving. And those folks who put questions in that we haven't had a chance to get to yet, don't worry, we'll follow up on them. So please keep them coming. But I think at this point, we're going to jump forward to Dr. Miller, and she's going to explain to us, when we talk about chronic pain, certainly one example is migraines. And so Dr. Miller, would you mind telling us what is a migraine?
What is a migraine? That's a great question. So there is a definition of migraine. I had a CSU student the other day. She came in the office. She goes, I don't have migraines. I have headaches, and I want you to get me better. And it's like, oh, wait. Let's go over the definition of migraine. So migraine is a headache that lasts usually 4 to 72 hours. But when I ask this question, how long does your headache last? It's how long does your headache last without treatment? So some people will come in the office, my headache lasts an hour because I took something. So if you didn't take anything, how long would that headache last? It has to last 4 to 72 hours. And you have to have five attacks. Now you have to have 4 pain characteristics. It has to be unilateral, pulsating, moderate or severe pain, and aggravative activity, or you avoid activity. But you don't have to have all those 4. You only have to have 2 of the 4. So unilateral, pulsating, moderate or severe pain, and aggravating with activity, or you avoid activity. And you only have to have 1 of 4 symptoms: nausea, vomiting, sensory light, and sound. So she came in office, her pain was bilateral, it was pressure, it was moderate to severe. She avoids activities such as climbing stairs, and she has light sensitivity and nausea. And she's had 5 attacks lasting 4 to 72 hours. She has migraine. So I go over the definition of migraine first with my patients to try to find out, do they have migraine or not? So just diagnosing migraine is really underdiagnosed. So just going through the criteria, and then chronic migraine is a little different. Chronic migraine, you have to have pain for 3 months, and you have to have 15 headache days per month, and 8 of those days have to be migraine. So sometimes in our office, Augusto and I will ask a patient, how many headache-free days do you have? Because they have 28 days of migraine or headache. So we reverse that question. Instead of how many days do you have migraine or headache, we say how many headache-free days. Now, this is a chronic, lifelong disease. It's highly prevalent. It's debilitating. I've had patients come to my office and they have a migraine. They're debilitating. They're crying. They're upset. They can't do anything. Their quality of life is poor. They avoid activities because they're afraid to get pain. And during the pandemic, people came into the office to get their medicine, to get injections and other things, or Botox or other things, because they didn't want to have pain. So 40 million Americans live with migraine. 1 billion people worldwide have migraines. Migraine is the overall 2nd leading cause of disability worldwide after low back pain. 1 in 3 patients avoid planning activities because they fear having to cancel. And they do that. They don't go to weddings, they don't go to graduations, they don't go to movies, they don't go to soccer games with their kids because they're afraid they will be debilitated. 3 in 4 patients report difficulty attending and functioning at work. Migraine affects women 3 times more than men. And the onset is teens or early 20s. So this is a very young disease. It's a brain disease. It's a chronic disease. It's a lifelong disease. And our job as healthcare providers is to control their disease, to control their migraines, so they can do things that they want to do and not have to cancel things. I tell patients that basically sometimes the cause of migraine is because of family history of migraine, that they just inherited a brain that is genetically more easily irritated because there is a high family history of migraines. So what causes migraines? So in the last few years, they found that there is a neuropeptide, not a neurotransmitter, but a neuropeptide, a smaller molecule. It's called CGRP. CGRP stands for calcium-tonin gene-related peptide. So this is a molecule that is found in the blood. So they tested in blood with people with migraine. What they found, people with migraine, they had a little bit higher level of CGRP compared to patients without migraine. And they also found when patients get a migraine, they have high levels of CGRP. So they tested in the blood again. So they test the blood before they have a migraine, and then they test the blood for CGRP when they have a migraine. So high levels of CGRP. Then, for example, they gave them an Imitrex injection, so a sub-Q sumatriptan injection. They measured the CGRP again, low levels. Then what they did, they infused CGRP through the vein in people that have a history of migraine, and it induced a migraine-like attack. They infused CGRP through the vein, the substance, in people that do not have a history of migraine, and they did not get a migraine. So then they found out maybe CGRP is one of the bad players in migraine. And if we can control the levels of CGRP, if we can keep CGRP down low, maybe we can control migraines. And that's really one of the causes of migraine, is having higher levels of CGRP in patients. So I have patients in my office, they get an MRI of the brain, the MRI is completely normal. And they're like, well, they want to have something abnormal in the brain. And I don't, because I know migraine is basically, they have some abnormal levels of CGRP. So our job is to get these levels down. So I explained to them that they have really an abnormal trigeminal vascular system. That's the fifth cranial nerve. Now, the fifth cranial nerve is sensory nerve. The sensory nerve is here, 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 and here, along with C2 and 3. So if I can control this trigeminal nerve, the fifth cranial nerve, to decrease the sensation here, we can control their migraines. And that's what we've done with a lot of these medicines now. So the migraine pathophysiology, I think of the fifth cranial nerve. The fifth cranial nerve is going to secrete the CGRP from one nerve terminal of the fifth cranial nerve to another one, and that's the pain transmission. And then you're going to activate CGRP from a nerve terminal to other cells. We call them mast cells. Mast cells can secrete all these bad players called cytokines, and they cause inflammation. Then the trigeminal nerve can secrete CGRP to blood vessels, and CGRP will vasodilate these blood vessels. So how do we kind of control migraines now? Next slide. So now we have medicines that kind of target CGRP. And how can we target CGRP? We can target it at the molecule. So we have these anti-CGRP antibodies, what we call monoclonal antibodies, that are going to attack CGRP at the molecule itself. Then we have these anti-CGRP receptor antibodies that attack CGRP at the receptor. So CGRP, this neuropeptide, can't bind to the receptor. And if it can't bind to the receptor, it's not going to go high. It's going to stay down low. We also have GPANs, which are smaller molecules that bind at the receptor of CGRP. And these are ways that we can block CGRP in patients. So this is kind of the pathophysiology of migraine that we're attacking now. Now, of course, migraines have triggers. We know migraines can be triggered by the weather changes, especially today. We had a lot of people come in the office because of migraines, because of the weather changes. Bright lights can trigger migraines. Tension, anger, depression, anxiety can trigger migraines. Skipping meals can trigger migraines too. You have skipped meals, you have a low glucose level, and sometimes you can trigger a migraine. You have menstrual cycles that can trigger migraines, as well as foods, red wines, aged cheeses, even medications can trigger migraines. So migraines we have now, we're going to try to target CGRP, and we're going to try to target it, first of all, with these monoclonal antibodies. So next slide.
If you don't mind, I might jump in with a few questions.
Oh yeah, go ahead.
I know several folks are pretty active in the Q&A right now, and they want to get to the end of the presentation. They want to know, well, how do we treat and fix all of these things? So
Right.
those of you who've asked some of those questions, don't worry, we're gonna circle back to that as we continue to move forward over the second half hour of our talk here. You know, one of the things I was interested in, Dr. Miller, is this idea. So it sounds like elevated levels of CGRP can lead to migraine. Is that correct?
Right. When you have a migraine, you're going to increase your level of CGRP in your brain. And so our job is to say, stop that, get that bad player down. And how can we do that? We're going to bind to the molecule. We're going to bind to the receptors. So the CGRP can't bind to these receptors and go high. So we're going to keep them down low. And we can do these through the monoclonal antibodies and also the GPANs. The monoclonal antibody is the big molecule. And so it has a long half-life. Right.
Do we have any idea why this is the case in some folks and not others? Why do some people have a hard time controlling this elevation of CGRP that leads to the migraines?
Right. And that's why sometimes there is a genetic component. So basically, they've kind of inherited a kind of hyperactive brain. And so what our job is to do is control these neuropeptides. And the way that some of the ways that we control these neuropeptides are with different medications. So this is our large molecule approach. This is 4 monoclonal antibodies. These are big molecules, so they have a long half-life. They're going to stay in your body a little bit longer. So their half-life can range from 21 days to 31 days. And we've had a lot of success with these medications. So the first one I'm going to talk about is the first one that got FDA approved. It's called Amavig. So Amavig, you can inject 70 milligrams, 140 milligrams sub-Q. So there's an auto injector. You take it out of the refrigerator for 30 minutes. You inject once a month. And hopefully we reduce that CGRP and reduce their migraine days. So patients have more headache-free days per month on these monoclonal antibodies. So these are long-acting, long half-life medications. So usually I start at 70 milligrams, and if a patient, say, is at 4 months and they're about 40% better, I'll go to the 140, but some people stay at the 70 milligrams every month and do very well. Now, Amavig binds to the receptor, a little bit different than the other monoclonal antibodies. It binds to the receptor, so CGRP cannot bind to that receptor and increase. So that's where it blocks CGRP. Now, Vyepti, Emgality, and Ajovy are a little bit different. These are monoclonal antibodies that bind at the molecule of CGRP, so it can't get to the receptor. And Vyepti is a medication we use in our office. It's an IV medication through the vein. Patients come into our infusion center every 3 months, and they stay there for 30 minutes. You start at 100 milligrams, and then every 3 months, if I need to, I'll go up to 300 milligrams every 3 months. Emgality is another medication. It's a sub-Q injection with a loading dose. So patients will take 2 injections to start off, and then 1 injection monthly of 120 milligrams. So this is another monoclonal antibody binding to the molecule itself. Now, Ajovy is another medication that is a monoclonal antibody, and it's a little bit different. You can inject once a month, or you can do 3 injections every 3 months. And again, these are the last 3 are monoclonal antibodies that bind to the molecule itself to reduce the levels of CGRP, so patients have more headache-free days overall. And these medications have really worked, and it's game changer. I had a patient the other day. She goes, "Can I just hug you?" And I said, "Yes, you can hug me." Her quality of life is markedly improved because of these medications. I've been a physician since 1986, and migraines and headaches are hard to treat. And now it's so much easier to treat patients with these medications that I have so many tools in my toolbox that I give hope. We give hope to patients now that didn't have hope before. Before, I remember patients would come in the office, they'll say, "Oh, my doc just told me to go live with it. I'm here to try to get better." And it's like, "Oh yeah, game on, let's do it. We can get you better because now we have all these medicines." So Amavig is, I said, once a month injection, different dosages, binds at the receptor. The other 3, one's IV and the 2 are sub-Q, they bind at the molecule itself. Now, these are bigger molecules, longer half-life, stay in your body a little bit longer. You take it out of the fridge, let it warm for 30 minutes, and then inject. But we also have the G-PANTs. The next slide. G-PANTs are smaller molecules. And when I tell you about smaller molecules, they have a shorter half-life, so they don't stay in your body as long. For example, Nurtec has an 11-hour half-life versus the other medicines I talked to you had from 21 days to 31-day half-life. So this is a shorter. G-PANTs are smaller molecules, shorter half-life, and Qulipta is the other one. It has a half-life of 11 hours also. So these G-PANTs are now preventive. But Nurtec is an oral medicine. You put it on or underneath your tongue, 1 pill every other day. And what they found in 1 week, they had a 30% reduction in weekly migraine days. And then at weeks 9 to 12, you had 4.3 more headache-free days. That's awesome. It is. For patients, these for episodic migraine, Nurtec and Qulipta are FDA approved. Qulipta is Jotapent. So with they come in different dosages. They come in 10 milligrams, 30 milligrams, and 60 milligrams. I had a patient the other day, she's on dialysis. She goes, "I can't take anything because I'm on dialysis." I said, no, that's wrong. Okay, we have a new medicine on the market, 10 milligrams you can take. So she was so happy. She has a preventive now that she can take for her migraines. So with 60 milligrams of Qulipta at 12-week clinical trial, they had a significant 54% reduction in the mean monthly days of migraine compared to 33% placebo. And over 60% of the patients cut their migraine days at least by half compared to placebo at 29%. So the migraine day reduction was observed at day 1 after the first dose, week 1, and month 1. So these are smaller molecules, shorter half-life, and helped patients, if they don't want to take sub-Q injections or IV injections, now we have options with these G-pants. Some of the side effects can occur with Nurtec. You can have nausea, abdominal pain, and with Qulipta, you can have nausea, constipation, and fatigue, but everybody's different with these medications. But what I think of is you have choices. You give hope to patients that didn't have hope before with these medicines. So these are the G-pants, and these are only approved for episodic migraine. Now, the monoclonal antibodies that we just talked about, the bigger molecules, they're FDA approved for migraine prevention. That means acute migraine abort methods, it's not, but preventive. So these monoclonal antibodies are used to prevent chronic migraine and episodic migraine, where Nurtec and Qulipta, only episodic migraine. And episodic migraine is less than 14 headache days per month, and chronic migraine is 15 or more headache days per month with at least 8 of those migraine. So different indications for these medicines. Next slide. Okay. Now we talk about how do you abort a headache? We know how to prevent a headache now with these medications. And patients with chronic migraine, we use a lot of Botox injections, and that's FDA approved for chronic migraine prevention, not episodic. So we have preventive therapies that we talked about, the monoclonal antibodies and the G-pants, but now we want to abort. How do we abort a breakthrough migraine? Because hopefully we have patients that come in the office and I haven't had a migraine in 3 months. That's awesome, but we don't always have that. So patients come in and say, what do I have to do? What do I do if I have a migraine? What can I use? Well, triptans were FDA approved in 1992, and triptans are Imitrex, Maxalt, Zomig, Emerge, Frova. Those are triptans, and triptans can vasoconstrict blood vessels. So I had a patient the other day that came into my office. He has 5 stents 8 months ago. He can't take a triptan. It's contraindicated. He has cardiovascular disease. He cannot vasoconstrict these blood vessels. So what can I use? I can use these G-pants. The G-pants are smaller molecules. They don't vasoconstrict blood vessels. And so we have options now to abort their headaches. Triptans have sometimes a long half-life. You have Frova that has a half-life of 26 hours. Emerge has a half-life of 6 hours. But triptans, they bind to 5-HT1B, and 1D, and reduce the release of CGRP, but also increase serotonin release. But again, they vasoconstrict blood vessels. So our patients with strokes, TIAs, myocardial infarctions, they cannot use triptans, or even if they have cardiovascular risk factors, hypertension, hyperlipidemia, obesity. Triptans, you don't want to use that on those patients, okay? They have too many risk factors. You don't want to vasoconstrict blood vessels. Now the G-pants, they don't vasoconstrict blood vessels at all, which is awesome. So your Nurtec and your Ubrelvy, those are 2 G-pants that are used to abort headaches. Nurtec is used at the onset of the headache on or underneath your tongue. It's only 1 pill per 24 hours. And Ubrelvy is 100 milligrams at the onset, and you can repeat it in 2 hours, 100 milligrams, depending if there's no drug-drug interactions with these medications that you have to make sure. But these are G-pants. Now, Nurtec has a half-life of 11 hours, but Ubrelvy has a little bit shorter half-life of 7 hours. So smaller molecules, they're going to bind to the receptor so that CGRP cannot bind there, and so it's blocked. What I like about these G-pants, they don't vasoconstrict. We already talked about that, but they don't cause medication overuse headache. So I had a patient that came in the office. She takes 2 Excedrin every day. So she's in medication overuse. She's been doing this for 3 months, and she goes, get me better. And it's like, okay, we're going to talk about medication overuse. And people sometimes will take triptans for more than 10 days a month. They're in medication overuse. Now, Nurtec, Ubrelvy, no medication overuse with these medications, which is awesome. Some patients can't take, or they're intolerant of other medications like triptans or ergotamines, or they can't take anti-inflammatories to abort their headaches. So then you have Nurtec and Ubrelvy as options. You also have a ditan. A ditan binds to 5-HT1F, and a ditan is a little bit different. That's called Rayval. Rayval is a medicine to abort, but Rayval can cause medication overuse, so you can't use it more than 10 days per month, and you can't drive for 8 hours after the medicine. So let me talk about Nurtec. Nurtec is 75 milligrams. Take 1 pill on or underneath the tongue at the onset of migraine. Most common side effect, nausea and 2%, 11 hours half-life, 86% of the patients treated with the medication did not use a rescue medication within 24 hours post-dose. That's awesome. So you want to try to limit patients' pills. You don't want to have them say, oh, I only have 9 pills. I have to make sure I keep them all because I'm afraid I'll use them. No, 1 pill, no rescue. And I have a patient, she came in last week. She goes, well, what happens if, Nurtec and Ubrelvy don't work? What are you going to do? And I said, well, you can use your Imitrex afterwards because she doesn't have any risk factors at 2 hours afterwards. So you have a rescue because it's different mechanism of action. But these medicines do help a lot of people that they don't need the triptans or other medicines. So it dissolves in seconds, results at 15 minutes in some patients, statistical significance at 1 hour for Nurtec, sustained benefits through 2 days for many patients, and there are some drug-drug interactions too. Ubrelvy, it comes in 50 milligrams, 100 milligrams, take 1 at the onset, can repeat in 2 hours if needed, not to exceed 200 milligrams a day or 8 migraines per month. Side effects, can be nausea and sleepiness, and about 5 to 7 half-life is elimination. So a little bit shorter half-life than Nurtec. Pain relief at 2 hours, 61%. And pain freedom at 2 hours, 21% versus 11%, and sustained pain freedom for up to 2 to 24 hours. And that's what you want. You don't want patients have to repeat medicines. You want their headache gone at the onset of their medicine. And that's what happens with these Gepants. They're also looking at another Gepant, which is a nasal spray. We don't have that yet on the market, but hopefully soon that'd be another option. But people, when they take a medicine, they want their migraine gone. They don't want to have to go lay down in a dark room. They don't want to have a foggy brain afterwards. They don't want to have side effects like they sometimes do with their triptans or even ergotamines. And these are medications that are just a lot cleaner and a lot safer for patients. It's amazing. So when they get, 16 pills or, 8 pills, they have extra when they come back to the office. It's a game changer. It really is in patients' lives. That's what I think. Next slide. So I'll also use this device pretty much in my office too. So some of the patients come to my office and they don't want any medicines, or they want different options besides oral medicines. And I talk about meditation, yoga, different techniques you can do to try to reduce anxiety and fear of having a next migraine attack. But Nerivio is a device that you put on your arm, and it's 1 patch on the arm per migraine. So you have to put the patch on within an hour. You leave it on for 45 minutes. You pair it up with your phone, and hopefully this abort your migraine without any medication. And I've had a lot of success with this. So it's FDA authorized or cleared for ages 12 and older. So it's self-administered. You put it on the arm, as I said. It works through a conditioned pain modulation, where it basically stimulates the body's pain receptors in order to relieve acute and chronic migraine pain. It kind of increases serotonin and noradrenaline to abort your migraine. But you can use these patches. You can use 12 patches. 1 patch 12 times, which is nice. And you leave it on for 45 minutes. So this is an option for people that say, okay, I don't want any medicines, or I want different options with medicines that I can try. So some patients will take a Nerivio. If that doesn't work, they use a Nerivio, they'll use a Nurtec or Ubrelvy afterwards to try to abort their pain. But it's options again. These medicines have really improved patients' life. They have a better quality of life now. They have renewed hope, and it is a game changer for a lot of these patients. So in summary, you have these monoclonal antibodies, the bigger molecules that I've talked about, the sub-Q injections, as well as the IV formulation, that these monoclonal antibodies bind to the receptor or the molecule CGRP, and they prevent migraines. But they prevent migraines, they prevent episodic and chronic. And then you have these small molecule, these smaller kind of Gepants, the Nurtec and Qulipta, that help to prevent episodic migraine. So now these are FDA approved, which is really promising new treatments. And they don't have many side effects at all. No really significant adverse events. Then you have the magnetic and electrical stimulations. Some people use the Nerivio, some people have used the Cephally, and I didn't go into all of these, but they're all magnetic and electrical stimulations that are here to stay and seem to be effective with few side effects. Then we also look at behavioral treatments that are useful at each step of the migraine care. So patient education, relaxation strategies, biofeedback, cognitive behavioral treatment strategies, had a patient the other day, she came in, she goes, oh, I got it fixed. This really helped me. And I said, what helped you? She goes, I put a fountain on my desk and it helps relax me at work. And so I told another patient the same thing. And she goes, it didn't work for me. I was just in the bathroom all the time. So everybody's different with these things. I have a foot massager underneath my desk to try to mellow my stress, but everybody's different. So find out what works best for you and then go for it. So all these medications and therapies and techniques have provided renewed hope to improve the lives of those suffering from migraines. It is nice. I could talk all day about this. I know it's exciting.
Well, it is. It's really interesting, and that this actually kind of sets us up and brings back in one of the questions we had very early on in the chat that Dr. Miller, you could tackle, or Dr. Miravalli, you maybe sort of go in this direction. So feel free to jump in if you'd prefer. But you're talking about these different behavioral treatments and stress relaxation, or something like Nerivio, where you're modulating or stimulating pain receptors. And we started with Dr. Miravalli explaining that for there to be pain, this has to be created by your brain, right? It has to be recognized by your brain that these pain receptors are being stimulated. So is there a way to train or trick your brain, for lack of a better way to put it, that you're not actually receiving this sensory information?
Yeah, certainly, and I think that's the whole point of biofeedback and cognitive behavioral therapy, right? In a sense, what you're doing is making those subconscious or unconscious responses that our brain has, anxiety, tachycardia, blood pressure, that are associated with pain, trying to make some degree of control on those, make them more of a conscious state. And by training your brain in doing that, you can control of that secondary response that chronic pain can induce in the brain. So this whole point of, which we will cover in the next few slides, of hypnosis even, or cognitive behavioral therapy, has the basis of that is to try to train your brain to be able to control responses that otherwise were subconscious.
Well, I think maybe with that in mind, we'll let you keep going, Dr. Miravalli. We've heard a fair bit about the different types of medications and forms of action for migraine. Maybe you can talk to us a little bit about some additional ideas outside of just medication.
Absolutely. And so there are different consequences of untreated pain, right? So why do we want to treat pain? Not only to improve quality of life, but also there are all these secondary metabolic responses to pain, anywhere from poor appetite, weight loss, disturbed sleep, also weight gain through anxiety, right? So some people, because they are not moving as much, we were talking about the lack of movement, they end up having less exercise. Depression increases. We also know that irritability, physical and verbal aggression has been seen in patients. Not to mention that patients may become bedbound or wheelchair bound due to lack of mobility. So this is a serious problem. So what are the consequences and also the goals for the management? We want to improve quality of life in our patients. We want to reduce pain. We want to improve physical functioning and also affect and negatively impact that increased psychosocial distress that our patients can experience because of pain. So I find this chart to be kind of helpful in terms of understanding the different strategies that we have to treat chronic pain. Dr. Miller gave us a wonderful overview of the medications that we have, but there are also some other things that, as she mentioned, are helpful to our patients. And these may not be necessarily related to efficacy. That doesn't mean that, pharmacological is always better than non-pharmacological. We find that certain patients actually have a similar impact. And we also find that in certain syndromes, topical medications may be helpful. And sometimes we have to go all the way to surgical intervention or more invasive interventions to treat certain pains. We talked about mobility before, and I am a big fan of physical therapy for these patients, not only to prevent the secondary musculoskeletal consequences, but sometimes through the use of bracing or splints or certain strategies, we can help to prevent further damage. There are certain exercises that physical therapists can do to improve core function and balance that indirectly will affect the progression of pain. Of course, massage is important, and I always try to explain that massage is like any other intervention. It has to be done right. So if you're going to do that, perhaps do it in no pun intended, in good hands. And sometimes also keep in mind that chiropractic neck manipulations make things worse. We've seen a lot of consequences that are negative consequences of certain chiropractic interventions. So make sure to check with your doctor, your neurologist, before you actually decide to go into some of these directions. We talked about psychoeducation, hypnosis, behavioral treatments, and these interventions, as I mentioned before, had the intent to help you with the secondary effect of chronic pain symptoms. Dr. Miller mentioned about relaxation techniques. Biofeedback is something that has been studied. Interestingly, developed early on biofeedback or neurofeedback to decrease anxiety in army personnel, right? So in military personnel that was deployed to the war, to be able to allow them to concentrate on and have more of a task-oriented mechanism. And what they found is that through the process of neurofeedback, they were able to help these individuals to correct chronic pain symptoms. And that's how the field of neurofeedback evolved as a therapy. Cognitive behavioral therapy also helps in certain circumstances. One of our patients just asked if in the case of transcranial magnetic stimulation, that's another technique that is being used in different fields in multiple sclerosis for depression, for anxiety, for chronic pain symptoms, but also for fatigue. So there is a lot of interest in that field as well. As I mentioned before, sometimes we have to do more of a stretching exercises, some interventions that actually are intended to decrease or improve range of motion. Sometimes you have to immobilize a certain limb in order to allow for recovery. But sometimes it's the opposite, right? So you have to help to restore movement. That's why it's important to have a physical therapist on your team. And sometimes we have to resort to medications, particularly in neuropathic type of pain syndromes. And this is different to the interventions that Dr. Miller discussed for migraines. In the case of chronic pains, neuropathic symptoms, sometimes we use medications. And these are examples of different groups of medications used in pain symptoms. This is a chart from the most commonly FDA-approved medications, anywhere from the gabapentinoids, the gabapentin, pregabalin. We also often use tricyclic antidepressants. We also use SSRIs or SNRIs, which are also a category of antidepressants. We have a list of medication side effects that have been seen in these patients. We try always to avoid the use of opioids. The use of opioids have been seen with negative results, particularly in chronic pain symptoms that increase dependence and tolerance to these medications. So it's always good to keep that in mind and only use in very certain limited situations. And not to mention, as Dr. Miller mentioned before, these rebound symptoms that happened with the medication overuse type of situations. And these are the general principles, which usually we start with a low dose and gradually titrate to actually reach the level of efficacy. But it's also important to remember that if things are working, sometimes and not working enough, sometimes a combination of different medications works better than increasing the dose, right? So looking at different mechanism of actions and introducing a different approach sometimes works better than going on a higher dose of a single therapy. But also remember that if things are working and someone reached pain-free status at 3 months, then we should slowly taper down. That's something that in medicine we are not good at, is stop medications, right? We tend to keep adding things. So it's always good to remember to consider tapering the medication down in certain circumstances. There are other medications and interventions that we can consider: electrical stimulations, acupuncture, exercise, and sometimes we have to refer patients to chronic pain clinics for blockades, for surgical lesions, for spinal cord stimulation. So there are all these devices that actually pain specialists can actually discuss with patients in case medications and non-pharmacological approaches are not enough. And I see that Kathy is already here, so that gives me the sense that we are reaching the time in which I probably should stop and maybe allow for some Q&A.
Well, we're getting relatively close, but I have a few questions for the two of you maybe. So, one of the things you mentioned is that with all of these different options, pharmacological, behavioral, whatever they might be, they have the potential to improve and reduce pain, or they can actually, go the opposite direction. So, and that it's always wise to consult with your neurologist before charting a course of action. So since we have two neurologists with us in the room, I was wondering, for something like chiropractic care, what are the symptoms or conditions in which you might consider that as an option?
I know.
It sounds like never is the answer.
Well, I prescribe more physical therapy than chiropractic care. So physical therapy, massage, other things, acupuncture, acupressure, I found hasn't worked as well, but everybody's different. So I am more conservative with physical therapy and some of the other modalities than chiropractic care.
I agree.
And so maybe with this idea that everyone is different, do you find that it can really be a long road for each individual as you're trying out these different options and making your way through behavioral treatment, physical therapy, OT, whatever it might be? Is it pretty difficult to settle in on the right option for a given person?
It can be very difficult. And sometimes you'll go through different medications. For example, some patients will come in the office and they've been on Elavil, Pamelor, Cymbalta, Effexor, lisinopril. They've been on all these different medicines in different classes, Topamax, and they've had side effects to these medicines. So you have to get on your thinking cap. Okay, where am I going with this patient? What monoclonal antibody should I pick? A larger molecule or a smaller molecule? And then what to abort? And diaries are very important, and a lot of people don't keep up with the migraine diary. I wish they would. I have people, some of my engineer patients, they come in with graphs and everything else, and I just love them. It's like, this is great, but to keep a migraine diary is perfect. But yeah, patients can be very challenging because they've been on so many different medicines and had so many different therapies and nothing's worked. But you're there to, get them healthy, and a lot of times it works. It really does. It's like, okay, we're going to fine tune this part, and this hopefully will get better. And if you're a medication overuse, this is what we're going to do to try to get you out of medication overuse. Then when we get you better, we're going to start tapering off these medicines and kind of clean things up. So you're on less medicines, and the medicines that you're on work great. So it's fine tuning these patients, which is very rewarding.
Yeah, I think probably as a clinician, right, incredibly rewarding. I'm wondering maybe from the patient perspective, right, it can be probably a pretty frustrating road as you're going down this multitude of attempts. And are there things that you suggest for them in terms of maybe mental health or just sort of continuing to provide that hope as opposed to really getting worn out of saying, we tried 20 things already and none of them worked, I give up?
Oh, we don't give up that often. So counseling, medication management, therapies, sure, it all takes, it all is in benefit for the patient, but you want to give them hope. You don't want to give up. So you're going to think of something else or some clinical trial that we can put them in. So to me, you need them optimistic, you need to give them hope.
And the other principle too is, hopefully today we gave you the concept that pain is very complex, right? So rarely one intervention is good enough, right? So it's often a combination of different approaches, pharmacological approaches, non-pharmacological, but also time, right? So it takes time for these medications and approaches to actually reach level of efficacy that truly is meaningful. Sometimes patients come with a list of medications that they failed, and then you ask them, well, how long did you take it? Did you take it to enough time, or did you reach certain doses that actually are meaningful? And sometimes they didn't, right? So they jump very quickly from drug to drug. So it takes time, and sometimes take.
Dr. Miravalli froze on my end, I think. Oh, there he is. He's back. Well, you could tell his computer gave up because the time is up for us, I think. As we mentioned in the chat a few times, these sessions are recorded. I know we gave an awful lot of information, particularly Dr. Miller had all kinds of great information about pharmacologic interventions and the way that they might work and the different options that are out there. So this will be posted on our website in the very near future. And you're free to go back and watch and rewatch and take in all the information that you need. Kathy, I might turn it over to you if you have any last words.
Excellent, Brett. Thank you. Of course, I want to say a huge thank you for Dr. Miller and Dr. Miravalde and your expertise on the subject matter. That was excellent. Thank you. Thank you, Brett, of course, for moderating for us tonight. And of course, I would like to again recognize all of our sponsors for this evening. Please do check out their virtual exhibit halls on our website. Those companies include Bristol Myers Squibb, Biogen, Genentech, EMD Serono, Novartis, Theranica, AbbVie, Amgen, Lundbeck, and Biohaven. Hope everyone has a great start to their week, and thank you so much for joining us tonight. Have a good evening.
Thank you. Thank you. Thank you.